Hello, everyone. My name is Eduardo. I'm one of the internal medicine chief residents at Jackson. It is my honor to introduce our grand round speaker, Dr. Jose Lutzky. Dr. Lutzky is a professor of clinical medicine in the Department of Medicine, Division of Medical Oncology here at the University of Miami. He's also the director of cutaneous oncology, the cutaneous and ocular oncology site disease group lead, and medical director for clinical trials coordination unit. He completed his medical school at Universidade Federal do Rio Grande do Sul in Porto Alegre, Brazil, followed by internal medicine residency at Hospital das Clínicas de Porto Alegre and Mount Sinai Medical Center in Miami. He then completed a hematology and medical oncology fellowship at Columbia Presbyterian Medical Center in New York. Before his appointment here at the U, Dr. Lutzky served at the University of California, Irvine as director of melanoma program and co-chief at the Division of Hematology Oncology at Mount Sinai Medical Center in Miami. Dr. Lutzky is a prolific physician scientist, having authored 2 books, chapters, and over 70 impactful manuscripts, including journals such as New England Journal of Medicine, Nature Communications, JAMA, and Journal of Clinical Oncology. He's also the recipient of several prestigious awards, such as the American Cancer Society Audrey Myers Fellowship. Dr. Lutzky is the principal investigator in several funded and cooperative group trials looking to further advance the field of melanoma, specifically focus on novel strategies using immunotherapy. Without further ado, please join me in welcoming Dr. Lutzky to our grand rounds to discuss uveal melanoma, state of the science, and bench-to-bedside trials at Sylvester Cancer Center.
Okay, great. Thank you so much, Eduardo, for the kind introduction. As soon as you pronounce my name in the correct Portuguese pronunciation, I realize you're Brazilian. So today I'm going to focus on uveal melanoma. So uveal melanoma is a rare form of melanoma, only about 4% of melanomas, and it hasn't had that much attention. Just because really there was not much that we could do for these patients, but there has been a flurry of developments in the lab that have actually translated into the clinical arena that has really fostered a lot of research in this area. So I think now treatment and management of these patients looks a lot more hopeful. So let me just go through my disclosures first. These are my disclosures. And this is sort of how I structured, my talk today. Just talk a little bit about the disease in general, and then sort of hone in the 3 translational leads that have been generated here at University of Miami, specifically at Dr. Bill Harbour's lab at Bascom Palmer, that have led to investigator-initiated clinical trials in 2 of those, and probably in the 3rd lead as well. So we've been lucky here at UM to have had Dr. Bill Harbour and now Dr. Zélia Correa at Bascom Palmer that developed this very large clinical patient base of uveal melanoma, and more important, very robust lab that has generated a lot of these translational leads. So uveal melanoma is, like I said, a rare disease. There are about 2,000 new cases a year, only about 8,000 globally. And it's usually manifested in the choroid, as it's shown here on the right, but not infrequently it may involve the ciliary body and the iris. And those 2 latter presentations tend to be more aggressive and associated with poorer outcomes. Risk factors for uveal melanoma include the presence of choroidal nevi, melanocytosis, and familial uveal melanoma, which is rare, but it's associated with germline mutations in the BAP1 gene and NF1 gene, and also patients with dysplastic nevus syndrome. Interestingly enough, the history of a previous cutaneous melanoma is not a risk factor for uveal melanoma. Half of these patients will develop metastatic disease as they walk in the door. And of those patients who develop metastatic disease, about 80% of the patients will present with metastasis initially in the liver, and about half of the patients will have mostly disease confined to the liver or to just a few other extrahepatic sites. I'm having trouble advancing my, let's see, there. So here we show some of the most important differences between cutaneous and uveal melanoma. Incidence, I already told you about. We do not know what causes uveal melanoma, whereas in cutaneous melanoma, UV radiation seems to play a major role. The mutational profile is very different in uveal and cutaneous melanoma. Cutaneous melanomas usually have a high tumor mutation burden, and about half of them have mutations in the BRAF V600 gene, as well as NRAS, NF1, and KIT. Uveal melanoma has a defined set of mutations and has a low tumor mutation burden. Essentially, all uveal melanomas have mutations in GNAC and GNA11, mutations in the G proteins. And the patients that have high-risk disease will have mutations in BAP1, and then there are mutations in SF3B1, EIF1AX, and I'm going to talk about those a little bit more later. The primary management for uveal melanoma is local plaque radiation, nucleation, or external radiation. In terms of prognostication, the staging with sentinel lymph node biopsy is the best way to stage cutaneous melanoma. Uveal melanoma, we feel that gene profile actually is the best way to stage these patients or to assess risk. I already mentioned that the metastatic pattern is different. Most of the patients will have disease in the liver initially, followed by the lung, bone, and other tissues. And the most blatant difference is that there is a lot of treatment for cutaneous melanoma. And we really did not have any good treatments for uveal melanoma actually until very recently. And now, so this slide's a little bit dated. Now we do have an FDA approved drug specifically for treatment of uveal melanoma. So in terms of staging and prognosis, I mean, there's an AJCC classification. There's another staging system based on TCGA that's noted here. There is a European English prognosticator system, but in the US, we feel that the gene expression profiling is the best way to assess prognosis in these patients. And this gene expression profile has actually been developed by Dr. Harbour when he was still at WashU, and is now commercialized and widely used in the United States. And it's a profile using 15 different genes. 3 of these are control genes, and the other 12 genes actually divide patients into class 1 patients and class 2. So class 1 uveal melanoma, as you can see here, has an excellent prognosis, whereas class 2 patients have horrible prognosis. You couldn't see a wider split than that. And about 50% of patients that have class 2 uveal melanoma, 70% of patients with class 2 uveal melanoma will develop a metastatic disease within 5 years. And on the far right here, you can see that upon additional follow-up of these patients over 5 years, there was a subset of patients with class 1 disease that actually started to relapse late. And looking a little bit more into that, it was found that expression of PRAME, which is a protein that's expressed both in uveal as well as cutaneous melanoma, as well as some other malignancies. Expression of this protein actually separated the patients that did extremely well with class 1 from the patients that had late relapses. So class 1 PRAME negative and class 1 PRAME positive. PRAME also had some effect in class 2, but it wasn't as marked. So when you look at the gene expression profile and PRAME and compare it to TNM, it was really shown in this and other studies that the GAP PRAME appears to be superior to HCC staging. So that's what has been used. That's the prevalent way of prognosticating uveal melanoma in the US. It's not the same everywhere, mainly because of cost and access, or many places in the world do not biopsy uveal melanoma. But in the US, it has become the standard of care. So here is a model of how we think uveal melanomas evolve over time. And a lot of this work actually has been done by Dr. Harbour and his in his lab and a bunch of other people that are doing research in this area. It's felt that there are initiating mutations in the melanocyte, and these mutations usually involve G proteins, as I mentioned before, GNAC and GNA11, and the other two mutations listed there that are not as common. GNAC and GNA11 are present in about 90% of patients with uveal melanoma, but that's not seemed to be enough to generate a malignant phenotype. And there are progression mutations that occur and lead to the malignant phenotype. And depending on the mutation that occurs, the actually seems to correlate very well with the clinical course. Class 1 patients, class 1A patients usually have mutations of the EAF1AX transcription factor. Class 1B have mutations in SF3B1, which is a splicing gene. And class 2 patients that have the worst prognosis usually have BAP1 mutations that lead to BAP1 loss. In terms of primary treatment, the most common treatments include plaque brachytherapy or enucleation. We usually reserve enucleation for patients that do not have good potential outcome for vision preservation or have extensive local involvement that precludes brachytherapy. Plaque brachytherapy is really the most used form of treatment. You can see here an example. This plaque with radioactive material is attached to the site of the tumor, usually left there for 3 days. Patients in the hospital, it's taken out and achieves excellent control of the primary disease. Now, melanoma used to be called a disease that gives cancer a bad name. Now, melanoma recovered a little bit of its reputation, when we developed, data like what you see on the left, and this is for cutaneous melanoma. We're looking at 5 years now here, and we have data up to actually 7.5 years. We can say that we can cure probably 50% of patients with cutaneous melanoma. And if you look just 10 years ago, that figure was about 5%. But on the right, you see data from a large meta-analysis of 912 patients with metastatic uveal melanoma. You can see now that uveal melanoma is giving melanoma a bad name. The median survival here is less than 12 months. For patients that have liver-only disease or mostly liver disease, you can treat with liver-directed therapy. And there's a number of liver-directed therapies that are listed here. I'm not going to go into each one of them, but they are all used under different circumstances, and they can be very successful in containing the disease for a certain period of time. Eventually, the disease progresses, though. and becomes refractory to therapy. There are a couple of experimental liver-directed therapies that are available now. There's a percutaneous catheter that allows us to perfuse the entire liver with high-dose chemotherapy, and that has shown excellent results. And it is approved in Europe, not yet in the United States, but it'll be approved in the US pretty soon. We are embarking here in a trial with this intrahepatic toll-like receptor 9 agonist in combination with checkpoint inhibitors. And that is a trial that's being done in a few centers, has shown some good initial results. Unfortunately, immunotherapy doesn't work that well for uveal melanoma. I showed you the data of immunotherapy in cutaneous melanoma, which is remarkable. It can lead to cures in advanced disease, and that's not the case in uveal melanoma. I just want to point to the bottom here, where response rates are usually in the 3 to 12% range with median overall survivals. Not really great. And that's because we think uveal melanoma is primarily an immunologically ignorant tumor. There is no T cell infiltration in these tumors, and the mutational load, as I mentioned before, of uveal melanoma is very low, which does not lead to a lot of neoepitopes to stimulate the immune system to begin with. This is a study that was published a few years ago that looked at the non-synonymous mutation burden in uveal melanomas compared to cutaneous melanoma. And on this axis, we see the phenotypes. And you can see that for uveal melanoma, most of those tumors have a non-T cell inflamed or so-called immune desert phenotype with low tumor mutation burden. Whereas when you look in cutaneous melanoma, it's more evenly distributed, and most of these patients have higher tumor mutation burden. Now, we have tried to target the proliferative pathways of uveal melanoma in a number of ways. And here you see the central GNAC mutations and G protein signaling through the PKC pathway and then MET kinase pathway. There's also signaling through the AKT pathway, and there's a non-canonical signaling here through this HIPPO pathway. And there are trials that's listed here that have looked at inhibiting several or multiple steps of these pathways, but unfortunately, response rates have been very low, and this has not have had an impact in progression-free or overall survival. More recently, there's a combination of a drug that inhibits protein kinase C in combination with crizotinib, which targets MET, and that combination has preliminarily showed a very high response rate, but the patient numbers are still too small, and we have to see what happens there. We're also trying to target epigenetically these drugs. EZH2 does not seem to be a good target. The preliminary trials did not really show any activity. There are trials targeting histone deacetylases, the bromodomain proteins, and also proteins in the chromatin remodeling complex. And we're doing a trial with a drug that's doing that. But again, so far, no hits. There's some other strategies. There's an interesting strategy using inhibitors of PRMT5, which is a methyltransferase that leads to aberrant splicing. And the idea here is by inducing aberrant splicing, you generate a bunch of abnormal proteins that may contain neoepitopes that will then maybe stimulate the tumor microenvironment, and may be able to treat those patients then with immunotherapy or checkpoint inhibitors. The PKC MET combination is the one I just mentioned. We're going to need to wait a little bit more on that. Cell therapy has been used. There's data with a small number of patients treated with tumor-infiltrating lymphocytes with response rates around 25 to 30%, and that's being confirmed. There are engineered T-cell receptors that are targeting PRAME, and we are about to start a trial looking at that with a German company soon, hopefully. There are a number of bispecifics that are being tested targeting B7H3. There's a PRAME CD3 bispecific that's also being tested. And there are these T-cell redirectors, which actually led to the development and approval of tebentafusp, which is the first drug that has been shown and been FDA approved for the treatment of uveal melanoma. And so this is an engineered drug. One aspect of the drug targets GP100, which is an HLA-A201 restricted peptide that's expressed in melanoma, not only uveal melanoma, but also cutaneous melanoma, but highly expressed in uveal melanoma. So one end of this construct binds very tightly to GP100 in the tumor, and the other end binds to the T-cell receptor. And the idea here is as the T cells go by, they get attached to this complex and generates an immune response. So this trial randomized patients with metastatic disease. They had to be HLA-A201 positive because the target is restricted either to chemotherapy or to single agent immunotherapy. And you see the data here. It was published in New England Journal of Medicine recently. There was a 14% absolute improvement in 1 year survival in the group of patients that received tebentafusp. So this has become sort of the standard of care for patients that are HLA-A201 positive. This is not an easy drug to give. It's given weekly. It requires a hospital admission for the first 3 infusions. It's expensive. It does provide survival advantage, but you don't see a plateau here. So it's probably a good framework for combinations. Now, I showed you that you can predict the 70% of patients that will develop metastatic disease right off the bat by doing the gene expression profile. And so the next question is, why don't we try to prevent recurrence? And it hasn't really been for lack of trying, as you can see here in this long list of adjuvant therapies to try to prevent a recurrence of disease in these high-risk patients. Problem is we didn't really have a lot of effective drugs to begin with. So I'm now going to go into BAP1 mutations and its relationship to class 2, because that has led to one adjuvant trial that we have proposed here. So Dr. Harbour's group actually was the first group that reported that BAP1 loss is very frequent in patients that have aggressive uveal melanoma. And these patients are class 2 melanomas. So BAP1 stands for BRCA or BRCA1 associated protein. It's in chromosome 3, and a loss of heterozygosity of chromosome 3 leads to a 2-hit inactivation of BAP1. BAP1 also has been associated with some familial syndromes. Germline BAP1 loss is associated not only with uveal melanoma, but with the diseases that are listed here. So the idea is it possible to therapeutically target BAP1 mutations? So what does BAP1 do? BAP1 does a lot of things. It's involved in DNA damage repair, is involved in apoptosis, involved in tumor cell metabolism, and it's involved in development and cell identity. It's involved in melanocyte maturation. So BAP1 regulates the switch from melanoblasts to melanocytes. So we have here the neural crest cells that become primitive melanoblasts, and then differentiate into melanocytes. But this occurs when BAP1 is present and active. When BAP1 is deleted, then melanoblasts do not differentiate. And in some of the preclinical models, you see this extensive pigmentation that is akin to melanoma. So when BAP1 is present, there is differentiation. And how does BAP1 do that? And Dr. Kuznetsov at Dr. Harper's lab has published this paper that showed that histone deacetylase class 4, HDAC4, seems to be the mediator of this process of differentiation. And it seems to do that epigenetically by restricting the localization of HDAC4 to the nucleus. Now, the question is, could we find a drug that could inhibit HDAC4, and would that recapitulate the differentiation that's seen when BAP1 is present? So this is a high throughput screen that was done in two phases. First phase is to select for drugs that are able to restore the differentiated phenotype in Xenopus frogs. And the second screen is for safety. And the drug that came out of that is a drug called quizzinostat, which is an HDAC4 inhibitor. And here we see the experiment with quizzinostat, showing that quizzinostat will rescue the normal phenotype in BAP1 mutated embryos. So this is how it should look in the controls. This is a BAP1 mutated embryo that shows abnormal phenotype, back of maturation. And here is when they're treated with quizzinostat that restores the normal phenotype. And here we're looking at mouse xenograft growth of human tumors. There's three different lines here. There's two BAP1 mutated uveal melanoma cell lines and one wild type. And you can see that quizzinostat will prevent growth in the BAP1 mutated, but not in the wild type. And it's more visually apparent here in the two mutated lines compared to control. There's suppression of growth, but that doesn't seem to do anything to the BAP1 wild type lines. So the idea was to try to use quizzinostat as an adjuvant therapy in a very high-risk population. And we looked at the data from the validation trial that led to the approval of the gene expression profile test. And there were about 1,600 patients there. And when we looked at the subset of patients that had a tumor size, tumor basal diameter of less than 12 millimeters and class 2, that's that curve of very high risk patients. And in these patients, the median time to metastasis was 32 months. So we put together this trial, and this is we're the coordinating centers, and we have 6 other institutions that see a lot of uveal melanoma that are participating. And what we want to do is to decrease the rate of distant relapse at 32 months. And we want to change that rate from 50 to 25%. Kind of a long shot, but that's where we're looking at. In addition, we'll look at other endpoints, and we'll do a lot of exploratory testing as well. We want to look at histone and non-histone acetylation. We're looking also at circulating cell-free DNA and to see if we can correlate that with recurrence. So this is the schema. So patients they have to have these characteristics. They're treated for 1 year with this drug 3 times a week, and then they have usual assessments, radiographic assessments, and the relative assessments. The trial is ready to go. Unfortunately, there were some geopolitical situations that prevented us from getting started because the drug is not yet available. The raw materials are made in China, and with the COVID situation, the facility there was not producing. It couldn't send it to Switzerland, where the drug is actually made. So my understanding is that as of December or January, we should be able to get the drug and get the trial started. So based on the same concept, Dr. Correa is looking at a neoadjuvant concept. For those of you that are not oncologists, when we say neoadjuvant, it means we want to give the drug before the treatment of the primary tumor. And here what we want to see is to see if we can change a class 2 phenotype back to a class 1 phenotype in these patients. And we're selecting patients that have very large tumors, no potential for visual preservation, doing a biopsy, treating, if they're class 2, treating them for 2 weeks with the drug, and then doing the enucleation or final surgery and looking at that tissue. And we want to see if the phenotype has changed back to class 1, in which case it would make sense to do a larger neoadjuvant trial in these patients. Now, switching to the second translational lead that was generated at Dr. Harber's lab, Michael Durante wanted to look at the tumor immune microenvironment, and did this by looking at single cell RNA-seq, which is shown here. These are 60,000 cells, and here it's honing into the immune cells, and you can see there is a very robust, varied tumor microenvironment in these melanomas. These are uveal melanomas from both primary and metastatic tumors. So Michael actually looked at the CD8 T cell compartment and looking for T cell exhaustion markers. And what he found was there was a significant overexpression of LAG-3. LAG-3 is a checkpoint inhibitor, same as PD-1 and CTLA-4. And you can see there's not a lot of CTLA-4 expression here or PD-1. And you can see this LAG-3 overexpression is both in class 1 as well as class 2 tumors, as you can see here, and as you can see by immunohistochemistry here. So we thought that maybe that's why uveal melanoma doesn't respond well to blockers of PD-1 and CTLA-4, and maybe we should try to use a LAG-3 blocker. So here is really just showing that the most abundant compartment where these LAG-3 cells are, LAG-3 positive cells are, is the CD8 T cell compartment. So in here, also I'm showing you a publication by Dr. Carlson from Sweden that actually validated this finding. And there has been further validation by other investigators since. So just very quickly, LAG3 acts on the interaction between the tumor cell when it's presenting antigen in the context of the major histocompatibility complex to the T cell receptor. And this is known as the first signal of immune stimulation. Now, LAG3 bridges that gap and inhibits this interaction. At least that is one of the activities of LAG3. LAG3 seems to have a number of other activities. So blocking LAG3 should restore first signal for signaling. So that led us to do this trial, put this trial together with nivolumab, which is a PD-1 blocking antibody, and relatlimab, which is a LAG3 blocking antibody. It just presented this at the Society for Melanoma Research in Scotland last week. So it's the first trial of this combination in uveal melanoma. There is data in cutaneous melanoma that shows efficacy, and for that reason, the combination has been approved. So we wanted to look at response rate, and we wanted to do a number of exploratory studies looking at the tumor immune microenvironment, looking at the receptor expression profile pre and post treatment. So this was investigator initiated, Simon two-stage design. We wanted to see if we could increase response rate from 5 to 20%. So patients should not have had previous immunotherapy, and they got this combination for up to 2 months or until progression or intolerable toxicity. So we screened 24 patients, we enrolled 22. The trial is still ongoing. We're going to 27 patients. 5 patients are still on active treatment. 17 are out because of progressive disease. I'm not going to really bore you with the details, but our response rate so far is 10%. About a third of the patients have stable disease, and half the patients have progressed. So this is the waterfall and spider graphs, and you can see the 2 responses here. You know, a number of patients with stable disease, and here you can see the course of the disease over time. There's still a number of patients that are stable for 9 months or so. The 2 responses have progressed. One of them is still being treated beyond progression, relatively stable. So these are progression-free survival and overall survival curves. The median overall survival so far is 11.2 months. Again, the bottom line here is that the adverse events are similar to what was seen in the cutaneous melanoma population. There are no new safety signals here. So we do have some preliminary data from the correlative studies, and this is not really ready for prime time yet. I'm just going to say that we have identified genes that are expressed differentially in both the circulating and the tumor infiltrating cells for pre-treatment versus post-treatment. So we need to analyze this a little better, and hopefully we'll present that data in the upcoming meeting. So this is looking at what's out there. This is single agents, a series of patients treated with single agent immunotherapy. These 2 are the largest series. Remember, this is a rare disease, the largest series treating patients with combination, and this is our early results. It's hard to compare this because these patients all have different degrees of tumor burden, different degrees of involvement. I'm not sure we can really compare this in terms of efficacy, but we can compare in terms of safety. The combination treatments are quite toxic. Single agent treatment is less toxic. This falls within the range of what we see in cutaneous melanoma. So I think that this is at least a reasonable first-line treatment option, particularly for patients that are not candidates for the tebentafusp because they're not HLA-A201 positive. And I think this is maybe is going to be a platform for other combinations. So these are all the people that contributed to this trial. I wanted to acknowledge them here. And last but not least, I wanted to talk a little bit about the role of macrophage dysfunction in uveal melanoma. There's a number of publications, mostly by Dr. Martin Jaeger, who has published extensively in this area. And the question is, what is the role of BAP1 in macrophage dysfunction? And I'm sorry, I think I'm missing one slide here. Oh, I am. I'm sorry. Forgive me 1 second. It's hidden. Okay. I really need to show this. Okay. All right. So this is the work of Christopher Kaler, who was a medical student at the time that he did this at Dr. Harbour's lab. He is an MD now. Chris looked at the role of BAP1 in macrophage activation. So MERTK is an essential protein that drives M2 polarization. So when MERTK is active, is phosphorylated, macrophages polarize from M1 to M2. M2 are immunosuppressive, M1 are immunofacilitator. This is really encapsulated a lot of work that he did, and it's all in his paper that's referred to here. But what he showed is that in class 1 tumors that do not have BAP1 loss, as I mentioned before, there is a lot of BAP1 here. This gene PROS1, which actually codes for protein S, is upregulated, and PROS1 upregulated, PROS1 upregulation upregulates MERTK. And here we look at the phosphorylated MERTK. So there's no PROS1, there's no MERTK, and CD163 is the phenotype for M2 macrophages. So not a lot of those. In class 2 melanoma, class 2 uveal melanoma, where there is BAP1 loss, there is upregulation of PROS1, upregulation of MERTK, and a lot of CD163. So the model that was created was that in class 2 tumors, there's upregulation of PROS1, and this has been shown to be epigenetically mediated by BAP1. That leads to upregulation of MERTK and increased phosphorylation of MERTK, leading to polarization of the macrophages towards M2, which is not what we want. So the idea is that maybe we can inhibit MERTK. Right now, there are in vivo experiments using a syngeneic uveal melanoma model with BAP1 knockout. That's being done by Dr. Correa here and by Dr. Harbour at UT Southwestern to see if we can reproduce that in vivo. And the idea is maybe if that is the case, to look at inhibitors of MERTK as single agent or in combination with other drugs. There is actually a MERTK inhibitor that has undergone phase 1 trials for other tumors. It's available. We're talking to the company to see if they're interested in doing a trial. So I didn't want to end before talking a little bit about the Collaborative Ocular Oncology Group. So this is a group of 22 institutions, and they were mainly ocular oncologists, all ophthalmologists. And they, as you can see here, they covered the entire United States, and there was one site in Canada. So they were able to prospectively enroll 1,700 patients with uveal melanoma over a 2-year period. Remember, there's 2,000 in the US every year. So it's a tremendous tool to do clinical research. And they did not have a medical oncology committee. And that committee was created recently, and I'm part of that medical oncology committee along with my colleagues from Columbia, Philadelphia, and Houston. And we want to use this, the ability to accrue all these patients to focus on pilot adjuvant trials. So of those 1,700 patients, 600 of them were patients that were class 2 high-risk patients. So our plan is to do a number of parallel pilot trials and try to look for signals and pick the winner and maybe do a randomized trial from there. And I think that was, and I hope I didn't go over. I think I did okay.
Jose, as I understand now, is the proper pronunciation. Thank you. That was a tour de force and a wonderful review of bedside to bench and back to bedside of how one can approach a very, very difficult problem. It's quite, when I recently helped participate in the care of such of a patient with metastatic uveal melanoma, and I was perplexed a bit by patients that present with metastatic disease and already have impaired liver function. What is your tolerance for giving a drug that you know may have additional hepatotoxicity indices that are, but yet it's probably the best around? How do you go about that?
Yeah, it's it's not like we have a lot of alternatives. So I think if the disease is involving the liver extensively, and it's mostly in the liver. Sometimes we use liver-directed therapy. Y90 radioembolization actually seems to work very well for some of these patients. Although sometimes, if they do have a lot of disease, you may run into problems. I just had a patient recently that had Y90, and his bilirubin went up to 25 a couple of weeks later, and it's now 3 months later, and the bilirubin's back down to 2. So if you can weather that period without further complications, but it is a difficult problem. I mean, I don't think there's a right answer to that. All the drugs that we use can be hepatotoxic. Immunotherapy can cause immune hepatitis.
Yeah, thank you. Any other questions? Please unmute yourself. Otherwise, I'll congratulate Dr. Lutzky for really fabulous grand rounds and ask everyone to go to the chat to take the link for evaluation and receiving MOC credits. Wishing everybody a safe and wonderful day. Thanks again, Dr. Lutzky, and thank you, Dr. Saul, for your introduction. Everyone have a great day.
Thank you.